All right, welcome everyone to another Brain Translate Q&A session, this week with our stroke research team. My name is Brett, I'm from MS Translate, and we've been helping the Melbourne Brain Centre with their Brain Translate events. Tonight it's our pleasure to be joined by Professor Bernard Yan and Dr. Bruce Campbell. You may have seen some of their work throughout the week. As always with our Brain Translate Q&As, you can interact live with us while these are happening. So you can be watching this stream live on YouTube, and if you do have any questions, you can go to the Melbourne Brain Centre at RMH Facebook page and drop those questions as a comment under the event. And we'll ask them as we're going through. So I might just start by handing over to Professor Young, and if you just want to give a bit of an introduction to yourself and the research that you do, and then Bruce, if you want to follow on from that, and then we'll get stuck into some of the questions that we've had.
So, good evening, I'm Bernard Yan.
Welcome everyone to another Brain Translate Q&A session, this week with our stroke research team. My name is Brett, I'm from... Sorry, just good feedback. Go ahead, Bruce.
Yes, good evening, I'm Bernard Yan. I'm a neurointerventionist at Royal Melbourne Hospital Comprehensive Stroke Centre. So my research is mainly centred around the device developments for endovascular clot retrieval and also in imaging. Over to you, Bruce.
My name is Bruce Campbell. I'm also a stroke neurologist and interested in the imaging and acute treatment of stroke, particularly intravenous thrombolysis and getting the guys off to people like Bernard to pull clots out.
Excellent. All right, well, we'll jump straight into the questions. So Bruce, in the video that we highlighted yesterday, you described basic risk factors for stroke. However, can you talk about whether there are any other risk factors for patients who might have other neurological issues, such as epilepsy or MS, and do they come with a higher risk of stroke?
In general, not. So some of the diseases that we treat, particularly neurodegenerative diseases like Parkinson's and dementia, are associated with being older, and that's a risk factor, obviously. But in themselves, these diseases don't increase your risk of stroke. Bernard can jump in if he can think of an example where that's not the case, but epilepsy patients don't really have an increased risk of stroke. Works the other way, of course. Patients who've had a stroke have a much higher increased risk of epilepsy. Patients with MS, I'm not aware of any association between stroke and MS, and most of the other brain disorders we treat don't. Obviously, if you have one brain disease and then you have a stroke on top of it, it can potentially have more of an effect on you. There's only so much the brain can tolerate in terms of what it can compensate for, but there's not really a link. Bernard, do you want to add anything to that?
I think that's quite right, although the traffic between epilepsy and stroke goes both ways. So we now have some emerging evidence that patients who have epilepsy, and especially those patients who have been exposed to anti-epileptics for a long time, they do tend to have more silent strokes, but this is a very new area of research and we're still trying to work out the exact causal link.
Okay, fantastic. Following on from that, I guess, and this is to both of you, is there a familial basis to stroke etiology?
There is. So all of those risk factors I talked about in the video, the traditional ones, high blood pressure, high cholesterol, they all have a genetic predisposition. Most of them are not single gene disorders, so they're not like your parents had it, therefore you've got a 1 in 2 or a 1 in 4 chance of getting it. They're multi-gene involvement risk factors, so you might inherit a complex of 10 or maybe even 100 genes that slightly increase your risk of having higher blood pressure or having type 2 diabetes or of having high cholesterol, and all these things play into your risk factor profile. But of course that has a strong interaction with lifestyle and the environment, and all of those factors can be modified by appropriate exercise and diet and so on to try and minimize the risk. There are single gene disorders that cause stroke. We treat a rare condition called CADASIL, which is a very long acronym I won't bore you with, but that's what we call a dominant disorder where you do have a 50% chance of inheriting it from your parents. Very rare. Vast majority of stroke is this mixture of complex multiple genes that modulate risk rather than determining having a stroke.
Okay, fantastic. Moving on to talk a little bit about the treatment side of things. And Bernard, you might want to talk about this. How does TPA work, and how is it different to other therapies?
we'll get Bruce to answer that one first, and I'll take the next one.
No worries. So TPA is a clot dissolving drug. Most strokes are caused by a blocked blood vessel somewhere in the brain. The clot usually comes from somewhere else, so either from the heart, particularly if you've got this irregular heart rhythm that's increasingly common in our community called atrial fibrillation. So you get a regular heartbeat, heart's not pumping properly, the blood stagnates, and then you can have a clot form in the heart, and when it moves up to the brain, that's when it causes a stroke. You can similarly get clot in the big arteries in the neck that can then flick up to the brain. TPA is a way of trying to dissolve that clot. It activates, it's actually something we all have, but it's something that we supplement, if you like, to activate enzymes that you've probably heard from detergent commercials. Enzymes break down proteins, and the protein we want to break down in this case is fibrin, which is what holds clots together. So TPA leads to the breakdown of clot, and tenecteplase is a genetically modified form of TPA. It has some advantages. It's a lot easier to give. We can just give an immediate bolus of the drug rather than having to infuse it over an hour, and it's probably a bit more effective at opening the artery. It's a standard drug used in heart attack, and we're trialling it in ischemic stroke.
Okay. So are there any drugs currently used for other purposes that have been shown to be effective in stroke treatment?
That's a fairly broad question. I'm just trying to think if there are any particular things. Obviously, all the drugs we use for stroke prevention are used in cardiovascular disease prevention in general. So the statins for cholesterol, the blood pressure medications, the diabetes treatments, the aspirins and things are used in multiple disorders. Bernard, leap in at any stage if you can think of a good example of this. People have experimented with various antibiotics, with intravenous immunoglobulin, with things that stimulate blood cells, all in the hope of stimulating neural recovery. And so far, all those trials have been negative. So we haven't really repurposed any drugs that I can think of that improve stroke recovery just at the moment.
Thanks for that, Bruce. I agree. Look, I think the problem we have here is what we call the strength of the evidence. So certainly a lot of things have been tried before, such as traditional medicine, especially Chinese medicine, and so forth, but none of these have stood up to the scrutiny of scientific trials. So far as we know, when it comes to acute treatment for acute ischemic stroke, it really comes down to thrombolysis, which is either TPA or tenecteplase.
All right, well, I'll throw across to you now for this one then, Bernard. I'll ask you this one. How does endovascular clot retrieval work, and do all stroke patients undergo that procedure?
Okay, so the idea comes from, and I think this is an extension of what Bruce was saying, was that strokes are caused when an artery has been occluded by a clot, and the idea is an open artery is a good artery. So endovascular clot retrieval is a way to mechanically remove that clot. And endovascular is, in fact, a medical term to describe a way to get to a clot, which is by introducing a tube through an artery in the leg, and by threading that tube through the artery in the body directly into the target, which is an artery in the brain, without having to give someone a haircut and open up the skull. So that's what endovascular means. Now, we know that in 2015, we have 5 positive trials all showing the efficacy of endovascular clot retrieval, so we know the stuff works. But the problem, of course, is that this is only available, we believe, probably between 20 to 30% of all patients, and the reason is that they need to come into the time window, and we also need to be able to show that there is a clot on imaging, because if there's no clot, then you can't treat it. And so to answer your question, not all stroke patients can undergo the therapy.
I might just chime in there and say that it's really the treatment for the biggest strokes, so the really big blocked blood vessels, that TPA doesn't work particularly well for. And although Bernard mentioned 20–30%, that may even be higher than what we end up treating. But the important thing to remember is that these are the patients that are at the highest risk of going on to have a disabling stroke outcome. And so patients who don't have a big blocked vessel often do very well with TPA. Sometimes they do quite well without any treatment whatsoever, just with the body's natural recovery mechanism. So these are the patients that we're sending for clot retrieval are really the ones who need something to prevent severe disability, and that's why it's so important.
Okay. Well, sort of following on from that again, I guess mentioning that you need to be able to visualise the clot. Do you expect new neuroimaging advances to be able to impact on stroke management?
I think we need to take about 2 steps to ask why we need to use advanced neuroimaging techniques, and the reason we want to do that is because we've been dissatisfied by the old technique, which is contrast or non-contrast CT. And with non-contrast CT, we really don't have any certainty about how much of brain is dead and how much is available for salvaging. But with the new techniques, we are able to have a bit more certainty to calculate how much is dead and how much is salvageable. So I think this will have a major impact on stroke management. Bruce, do you want to add on to that?
Yes, so the technique we're using particularly at the moment is called CT perfusion, and it's using the same CAT scan technology we've always used to exclude blood in the brain, but really using contrast, which tracks where blood is flowing within the brain. And that functional information tells us if there's delayed blood flow, that the tissue is potentially at risk, and it will be contributing to what we see as the patient's symptoms, their weakness and their loss of vision or their loss of speech. And the areas that have virtually no detectable blood flow are the areas Bernard mentioned that are probably already irreversibly damaged. And knowing how big that area and where that area is, what the functional significance of that area is, really helps us make the best decisions about who we should be, doing various treatments in and really trying to get the best outcome for them.
Following on from the summary that we posted on Tuesday, Bruce, which was one of your studies, the Extend trial. So that trial showed that thrombectomy and TPA led to an early improvement of stroke symptoms. Why was that different to other thrombectomy trials that have been conducted previously?
In 2013, there were 3 trials published in the New England Journal, which were all neutral, and the biggest of which was the IMS-3 trial, which Bernard Yan and Peter Mitchell and I was involved peripherally over the years. So that was a trial that didn't use any imaging selection to identify even a blocked artery, let alone what might be salvageable or not. So it was a very broad inclusion, and they used old-fashioned devices that Bernard will tell you weren't that effective at opening the artery. And they also took a long time to treat patients. So really the new generation, and Extend IA that was done based at Royal Melbourne, Bernard contributed patients, the co-principal of Melbourne, and basically what we showed in that trial was very similar to the other trials that came out this year. They're all a very consistent message that if you identify a blocked blood vessel, you make sure there's not a really large area of dead brain already, and then you get the artery open quickly and effectively with the newer technology that does that well. Then you get fantastic outcomes for the patients. And so in our trial, you only needed to treat 3 people to get an extra person not disabled at the end of 3 months compared to what would otherwise happen. So it's one of the most powerful effects anywhere in medicine.
Okay. So going back to talking about the involvement of genes and genetics, but this time talking about whether or not they may be involved in complications for people that have had a stroke. Have there been any genes identified as predictors of those stroke complications, and can they be incorporated into clinical practice?
Bruce, you want to take that, Bernard?
Oh, okay. I was just going to say that not in general. The area that genes are somewhat recognised as something that Bernard's interested in, which is response to some of the drugs we use. So I might let him talk about antiplatelet resistance. But
this is an area called pharmacogenetics, and it's a way to make some kind of intelligent prediction of how responsive a patient is to certain medications. It's not quite in the area of acute stroke, but we've done the research in cases where we have to perform some kind of endovascular therapy, for example, the placement of stents in patients, some brain arteries, for the treatment of aneurysms. And we find that there are certain patients, if they have a genotype abnormality called CYP2C19, that these patients are genetically predisposed to having a much lower responsive rate to a certain medication that we use called clopidogrel. And in those cases, we are able to use the genetic information to modify the way we treat our patients. But this is, I think, somewhat different from acute ischemic stroke.
Okay. Moving on, I mean, one of the themes that seems to be coming up a little bit as we're discussing it, and in the summary that we talked about today on Brain Translate, it seems to be really crucial that treatment is provided as quickly as possible. In our video on Monday, Professor Davis mentioned
the key issue with stroke is we need a brain scan at the moment to distinguish what type of stroke it is. So in cardiology with heart attacks, it's very easy. They do an ECG, which is just the electrical tracing of the heart. Any ambulance can do that. They can diagnose a heart attack and then they can manage it as appropriate. But for us, the treatment for a bleed in the brain is totally different to a blocked blood vessel. And so at the moment, the only reliable way to distinguish that is to do a CAT scan of the head. And so what's been happening around the world, and we're hoping to do the same in Melbourne, is to put a CT scanner in an ambulance. Wouldn't fit in the standard one, so it has to be a special purpose-built ambulance. But if you can get the ambulance to the patient at their home, diagnose a stroke appropriately, perhaps even identify whether they've got one of these large vessel occlusions that people like Bernard can pull out. The idea is that we can then direct them immediately to the most appropriate site to have the clot retrieval and give them the intravenous TPA or lysis on the way. So it really does break into that space which we previously haven't had any access to, which is before the patient hits hospital. At the moment, hospital systems are getting much better. At the Royal Melbourne, we can usually treat people within 20 minutes if the team's on site. So there's not that much more bang for buck in going faster in that space. But there's often an hour, even 2 hours before the patient gets to hospital that we could use much more efficiently if we had the tools out in the field. And so that's what the idea of the CT and ambulance is. And we're hoping to get on with that hopefully next year.
Okay. One of the things that came up a little bit when we did our brain tumour feature week and the question and answer session for that was quality of life research projects. Are there any quality of life research projects associated with stroke, and how can you actually measure brain recovery? Does that form part?
Yeah.
Bernard?
I think the trouble with most of our stroke research or acute stroke research is that we only take our measurement of someone's recovery up to about 3 months. But we are now gradually learning that brain recovery, in fact, extends beyond 3 months, in fact, extend beyond 2 years. So there are some research projects headed up by our colleague, Dr. Nawak Yassi, who is looking at exactly this question of looking at more solid ways of measuring brain recovery apart from just measuring how these patients functionally perform during the day, but to look at advanced imaging or advanced brain imaging to look at the recovery of motor tracts and also sensory tracts. Bruce, do you want to add on to that?
Yeah, I think the most important quality of life issues for the patients are what they can do functionally, as well as things like fatigue and cognitive performance, which is not something that's been measured quite in quite a structured way before. So there are moves afoot to try and measure these things, and therefore once you measure it, you can start trying to intervene and change it.
I guess following on from that then, in terms of following up patients post-stroke, one of the things that we talked about a bit during the multiple sclerosis feature week was the development of wearable monitoring devices. Is there anything that stroke researchers are developing in that area?
I think there are two phases here. The question again comes back to why you want to get patients to wear the device, where you can get information easily and also easily by clinical assessment. And the real reason for it is manpower, because if you want to measure a patient's performance, you actually will need to dedicate a researcher or a nurse or a doctor to be at the patient's side to keep monitoring. And that is labor intensive and may not be that cost effective. So the idea of the research that we have over here is to use a monitoring device which allows for continuous monitoring of the patient independent of the nurse or the researcher or the doctor. So we are developing that here at Melbourne Brain Centre, but we're only monitoring those patients in the acute phase, for example, in the first 72 hours. And the idea is to use that almost like a house alarm to track if the patient recovers or rapidly deteriorates.
Did you want to add anything to that, Bruce, or happy with that answer?
That's Bernard's interest area, one of them anyway, yeah.
So tomorrow we're going to be featuring a video talking about stroke trials and how people can get involved. But while we have the two of you here, do you want to talk about, are there any trials currently underway at the MBC or planned, and how do patients get involved in those?
There are always lots of trials going on. Most of the ones that Bernard and I are interested in happen in the first few hours after patients hit the hospital with an acute stroke. So they're not things that you volunteer for in advance, fortunately. There are lots of secondary prevention studies. So people who've had a stroke and, you know, we want to reduce the risk of them having another one. There are studies at new cholesterol lowering drugs and new combinations of clot preventing drugs. So there are plenty of studies going on, and I guess they can be kept apprised of that on the Facebook page. But yeah, most of the stuff that Bernard and I do is very much the pointy end, which is not so much a community volunteer thing.
Okay. Just as we've been talking, we've just received a question from online that's directed towards you, Bruce. Question comes from Trevor. I think he might have met you previously, but I'll just move ahead. He mentions that he suffered a left medial medullary stroke caused by a left vertebral artery dissection. And he says which the clot's still in the area of the artery. Was there a particular reason as to why that couldn't be removed? And is there any danger of it dislodging and causing another stroke elsewhere? I might get you to answer that. There's a second question, but I might see if you can.
Sure. So the question about when you remove a clot is, as Bernard alluded to, about timing and also about location and whether it's accessible. So without knowing the specifics of that case off the top of my head, I'm not sure if it was within the first couple of hours that they would consider going up there. Most of the trials were actually not in the vertebral circulation, which is at the back of the head, but in the anterior circulation, the carotids and middle cerebrals. So there may also be some anatomical differences there. And the stroke type, you know, whether there's already established brain damage is one of the things we consider. So it's certainly not something we do in every patient, but if you come in quickly and there's a large area at risk of tissue at risk, then they're the patients that we're considering.
Okay. And there was a follow-up question to that asking whether or not they should have a CT scan in the near future to ascertain whether or not that clot's still in the same location.
Well, hopefully they've got some follow-up booked with their neurologist and we can discuss that in the clinic.
So thank you to Trevor for submitting that question. Hopefully that's answered it for you. Look, we won't keep Bernard or Bruce too much longer. I don't know if just to finish off, if the two of you just want to make some general comments about where you think stroke research is at, what the biggest developments are, and what you sort of think might happen, what the near future holds in terms of stroke research.
Yeah, I think what Bruce alluded to before was quite correct, is that we now know the earlier we intervene, the better it is for the patient. So there must be some sort of system whereby we're able to assess and scan and treat the patient as early as we can. So having mobile CTs, or in fact CT scans and ambulance time window, because for the moment we know that the patients most benefit in the first 6 hours But for those patients who come to our hospital or come to medical attention, some of these would be after or beyond 6 hours. So the 6 hour to 24 hour is a bit of a black box, and we don't know which of these patients will respond to our kind of treatment. So there are now trials underway to look at the 6 hour to 24 hour window to see if we are able to best identify those patients who can benefit. Bruce?
Yeah, I think the key really is for ischemic stroke, getting the artery open, and we've got better ways to do that, but I'm sure there's more room to push that further. So really trying to get the artery open as completely and quickly as possible. And then there's intracerebral hemorrhage, which we haven't talked about really tonight, and that's the other type of stroke that, although it's only about 15% of strokes, makes up equally contributes to mortality from stroke. So it's a very deadly type of stroke, and perhaps getting into that pre-hospital arena when those hemorrhages are really growing, and it's the growth that determines outcome. We're hoping that we'll be able to change the course of that type of stroke.
Fantastic. All right, well, I think we'll wrap it up there. Just to say thank you again to Bernard and to Bruce for giving up their time tonight. Obviously both very busy individuals, so we thank you for coming in and answering these questions. As always, if you do have any questions after watching the Q&A, you can submit them on the Facebook page or on the forum, and we'll get to answering those as quickly as we can. So thanks again, guys.
Thank you. Thank you, Bruce.
Thanks very much.
Thank you.
Thanks for attending, everyone in the audience.